Good morning. Thank you for joining us on the webinar today. My name is Haley Aka. I'm with the Health Policy Institute of Ohio. And I'm pleased to introduce this morning our most recent policy scorecard from our Addiction Evidence Project, focused on overdose reversal and other forms of harm reduction. I also get to help tee up a conversation that we're going to have with two excellent guest speakers, and we'll have that a little later on in the webinar. At HPIO, our mission is to provide the independent and nonpartisan analysis needed to create evidence-informed state health policy. We know that many of you are boots on the ground in the fight against addiction and may have some very detailed knowledge, specific knowledge about the individual policies and programs that we'll be discussing today. We hope that our work can serve as an opportunity to see the big picture view of harm reduction policy in Ohio. And we're also going to help provide you with the tools that you need to educate state policymakers and others on the status of harm reduction in the state, and present some opportunities to partner with other sectors to reduce the impact of addiction in Ohio. My colleague, Amy Bush-Stevens, and I are the co-authors of this report, and we lead all of the addiction-related work here at HPIO. So please feel free to reach out to us via email or Twitter. We love engaging with you all in this work. Throughout the webinar this morning, if you have questions or comments for any of our speakers, feel free to type them here in the question box on your screen. We've reserved some time at the end of today for questions and some dialogue. I also want to remind you too that slides will be posted at the end of today, not only our slides, but also the slides from our guest speakers, and those will be available to you at hpio.net. So here's how we're going to spend our time together this morning. I'll cover sort of the context, the purpose, and the process of putting together our report. Amy will dig into our key findings, and then we'll get to hear from our guest speakers. We're pleased to be joined today by Dr. Sean Ryan from Brightview and Zach Holmes from Columbus Public Health, who will update us on some harm reduction work that's currently underway in Ohio. All right, jumping into that context. The overdose death rate has been a topic of much conversation over the past several years, and really for good reason. In 2017, 4,864 Ohioans died of unintentional drug overdose, which is a historic high in Ohio. This increase, as you know, has been led in recent years by deaths related to fentanyl. And that's that yellow line you see taken off there. The monthly number of drug overdose deaths reached its highest point in January of 2017, and preliminary data from the Ohio Department of Health indicates that the number of drug overdose deaths began to decline through 2017 and into 2018. And we know this decline is not being felt everywhere. For example, overdose deaths in Franklin County have continued to rise. However, this may be the first sign that Ohio's many efforts to prevent and reverse drug overdose are beginning to have some positive impact on statewide outcomes. Still, overdose deaths really are just the tip of the iceberg when it comes to the impact of addiction on Ohioans. Just under the surface, we know that many Ohioans continue to struggle with substance use disorder and the many other harms related to addiction. And this includes health conditions such as hepatitis C, HIV, endocarditis, and non-fatal overdose, but also social and economic harms such as homelessness, job loss, incarceration. The rates of these addiction-related harms have increased in Ohio over recent years. For instance, we see here that new cases of hepatitis C increased by nearly 50% from 2014 to 2016, and they've remained high since then. Hepatitis C is an infectious liver disease that can be spread through the use of shared needles, syringes, and contaminated surfaces. And hepatitis C presents common sort of flu-like symptoms, which often go undiagnosed and allows related liver disease to progress over time. And unfortunately, it's estimated that approximately half of people who inject drugs are infected with hepatitis C. People who inject drugs are also at elevated risk for contracting HIV, both through shared needles and through risky sexual behavior. And although new diagnoses of HIV had been decreasing in Ohio for many years up until 2015, rates have begun to increase in the last several years. The number of HIV diagnoses among people who inject drugs has also increased in that time, from 6% in 2013 to 13% in 2017. Endocarditis is another addiction-related harm for people who inject drugs. This is an infection caused by bacteria that enter the bloodstream and settle in the heart. And over the last 10 years, there's been a 42% increase in the number of Ohio hospital encounters with people diagnosed with endocarditis. And this increase was largest, you see that red line there, largest for young adult patients between ages 18 and 39. This is the group most likely to use injection drugs. So harm reduction is critical to addressing and reversing the trend of these addiction-related harms. Harm reduction is both a framework for understanding substance misuse, and is also a set of policies and programs that aim to reduce the adverse health, social, economic consequences of drug use. Harm reduction addresses the conditions and consequences of drug use and incorporates a range of strategies, including overdose reversal, safer drug use, and abstinence in order to meet the needs of all people with substance use disorder. The purpose of harm reduction is to save lives, improve the quality of life for individuals who use drugs, and improve the overall health and safety of communities. Harm reduction is a key component, but also just one component of a comprehensive approach to addiction. We know that prevention, treatment, and recovery are also necessary components of this approach. And here we see the connections between these different approaches really from the perspective of the individual. So on the left, for people with optimal health, prevention strategies reduce the risk of future addiction. In the center there, for people living with substance use disorder, treatment and recovery services help folks stop using or abusing drugs and regain overall health. And then on the right, people with substance use disorder who are experiencing or at risk for additional harms related to addiction. Harm reduction strategies prevent or address these harms. So each of these areas are critical to addressing addiction in Ohio, and practitioners in each of these sectors are key partners in reversing the epidemic. The scorecard report that we put together here at HPIO focuses primarily on 4 harm reduction strategies, and these are strategies that impact a large number of Ohioans and also have strong evidence of effectiveness. And today we're going to focus on two of these strategies, the first 2. So the first is overdose reversal. This is the rapid reversal of an opioid overdose using naloxone. The brand name of that is Narcan. And then the second strategy are syringe service programs, SSPs. SSPs are sometimes also called syringe or needle exchange programs. They provide people who inject drugs with referrals to treatment and to new sterile needles to reduce the transmission of infectious diseases like HIV and hepatitis C. In the report, we also look at strategies to reduce motor vehicle crashes from drunk driving. These are strategies like sobriety checkpoints and ignition interlock laws. And then finally, we focus on housing first, which is a rapid rehousing approach. This is just one strategy that addresses the social and economic harms of addiction, like homelessness. There are also some newer harm reduction strategies, like safe injection sites and drug checking, fentanyl test strips, where the evidence base is just emerging. And remember, this list is of strategies with strong evidence of effectiveness. And because these newer strategies, the evidence of effectiveness is not quite as strong, it's still emerging, we've not focused as much on them in the report. So in order to assess our progress in implementing these evidence-based harm reduction strategies, HPIO created an addiction policy inventory and scorecard specific to overdose reversal and other forms of harm reduction. This report is the second in a series of reports that we've released as part of our Addiction Evidence Project. The goal of the Addiction Evidence Project is to provide policymakers and other stakeholders with information needed to evaluate Ohio's policy response to the opiate crisis, and then to accelerate and continually improve the strategies that we are implementing so that we can address substance use disorders in a comprehensive, effective, and efficient way. The overview of the project was released over a year ago now in December of 2017. The first inventory and scorecard report, that red report, focused on addiction prevention, treatment, and recovery, and it was released in April of 2018. And then our orange report on overdose reversal and other forms of harm reduction was released just a few months ago in November. These are the three aspects of each phase of the Addiction Evidence Project. For each phase, there's an evidence resource page, a policy inventory, and a policy scorecard. I'm just going to pause a second here so that you can absorb the different pieces of this. The takeaway here is that for each inventory and scorecard report, we look at the evidence for what works to combat addiction. We compare that to an inventory of all the things that the state has done. And then we put those together into a scorecard to show the strengths, the gaps, and the opportunities for improvement in Ohio's policy response to addiction. This is the framework for the Addiction Evidence Project. It acknowledges that many sectors are critical in addressing addiction. We'll be addressing each of these areas, either have addressed or will be addressing each of these areas over the course of the project. And as I mentioned, we just completed the second phase focused on harm reduction and overdose reversal. For each phase of this work, we've brought together an advisory group of experts from a variety of sectors to help us develop these reports. So thanks to those of you listening today who have served on our advisory group. We really appreciate your feedback. And if you'd like to see a list of the folks who have served on our advisory group, it's the two different lists are listed in the appendices of the reports. To create the policy inventory, we reviewed state-level policy changes from January of 2013 to May of 2018. This chart shows the number of overdose and harm reduction policy changes in that time frame as compared to the prevention, treatment, and recovery policy changes from our first scorecard report. And you'll see that of the overdose reversal and harm reduction policies in that orange box, most of the policy attention focused on naloxone distribution, access, and awareness. So distributing naloxone, making sure people know how to access naloxone, making sure people know what naloxone is. There was less focus on other strategies like Ohio's Good Samaritan Law, syringe service programs, HIV screening and treatment, drunk driving prevention. Amy will talk more about these gaps when we get into the key findings of the report in a minute. You'll also notice that compared to the number of policy changes in prevention and treatment, there is considerably less focus on overdose reversal and harm reduction in Ohio overall. Taking all of that data and information into account, we then went to our advisory group and to other public and private stakeholders and asked for input to ensure that we were really understanding how these harm reduction strategies are being implemented in Ohio. And then based on all of this information, we were able to rate the subtopics within overdose reversal and harm reduction as having either strong, moderate, or weak evidence alignment and implementation reach. So these are those ratings that we developed for the scorecard report. This is a really brief summary table that you'll see in our executive summary. There's more detail in the full report and even more detail in a separate detailed scorecard posted on our website. So if you're interested in any of these topics and digging further, there's much more detail to be found. All right, so now that we have some data and some background on the report overall, I'll turn it over to Amy, who's going to walk us through our key findings.
Good morning, everyone. This is Amy Stevens at HPIO. Thank you, Haley, for providing that background and context on this project. We're really excited to share this information with all of you on this soggy Tuesday morning. I'm going to be talking about what policymakers can do to lessen addiction-related harms. And I'm going to focus on these three areas here because they're particularly timely and relevant to the state policymaking landscape. And for each of these, I'll talk briefly about the policy strengths and gaps and identify some opportunities for improvement that hopefully we can all move forward with. First, I'll start with overdose reversal. And the evidence-based strategy here is spreading the use of naloxone. In terms of strengths, we've had a really strong policy focus on naloxone in Ohio at the state level. So you saw that bar chart a minute ago from Haley that showed all the policymaking activity in this area. Of course, there's also been a lot of activity at the local level with EMS and local health departments and other partners coming together. And Sean Ryan is going to be talking more about that in a few minutes here with an example from Hamilton County. State policymakers have implemented several changes to increase the use of naloxone, including expansions of Project Dawn, which I'm sure folks on the call are familiar with, and also legal protections for professionals who dispense or administer naloxone. We also have a Good Samaritan law in Ohio that provides some legal immunity for bystanders of overdose, although it could certainly be strengthened. Looking at the gaps, some Ohioans still lack access to naloxone. For example, we still have about 28 counties in the state without a Project Dawn site, and some of our Project Dawns have pretty limited programming, such as only being able to be open 1 day a week. Community organizations and lay people also face barriers in distributing and obtaining naloxone, largely because of the complexity of some of our laws and just lack of organizational capacity at the local level. Here are a few graphics from the report that illustrate these strengths and challenges. On this map, the yellow dots are the Project Dawn sites, and the darker blue counties are the counties with the higher overdose death rates. You can see that there's pretty good overlap here, but we do still have some counties with higher rates that don't have a Project Dawn. This chart highlights the importance of getting naloxone into the hands of bystanders. So this includes friends and family of people struggling with addiction. This is from a study that was done by the Department of Health and CDC, where they found that even though a bystander was present in about half of overdoses, bystanders administered naloxone in only 2% of cases. And if those friends, if friends and family who were there had naloxone, many more lives could have been saved. So a key question is, what has been the impact of all of the efforts around the state to reverse overdoses? And I'm going to share now a series of maps that help to answer that question. And these maps show the most recently available data from the CDC, and they're looking at rolling 12-month time periods from June of one year to June of the next year. This first map is looking at the percent change in the number of overdose deaths from June 2015 to June 2016. And on all of these maps, the red increase indicates the biggest increase. So keep an eye on Ohio here as we go through these maps. This is 2016 to 2017. And then here's 17 to 18. So this is the most recent period that we have data for. Note that the 2018 data is preliminary, but you see that Ohio is a nice dark green here. Ohio, West Virginia, and DC actually had the biggest decrease during this time period based on this provisional reported data. So one way to interpret this map is that all of Ohio's efforts have begun to pay off, which is certainly hopeful. But another interpretation is that the decrease reflects more of a change in the drug supply, such as a decrease in carfentanil. So this chart shows trends in specific drugs present for overdose, and you can see the huge jump that we had from 2014 to 2017 in fentanyl and related drugs. And we don't know for sure what explains the progress that we're seeing now. It's likely a combination of factors. So a result of all of the efforts that have been made to get naloxone out into the community, but also possibly a change in the drug supply. We are now hearing some reports from communities around the state, including Franklin and Cuyahoga counties, that they are seeing carfentanil back in the drug supply. So we, of course, won't know for sure what this trend is for a while to come. Looking at opportunities for improvement for overdose reversal, clearly we need to really be keeping our foot on the gas pedal for overdose reversal, and here are some areas that could make a difference. So the first is really increasing the number of community sites that distribute naloxone. In the report, we talk about different ways to increase access for friends and family and community members, so really going beyond EMS to get it more directly into the hands of the people who are most likely to be present when an overdose happens. Second, we could simplify Ohio's Good Samaritan law so that more bystanders are encouraged to call for help. And then finally, expanding the current media campaign that we have to make sure that more folks around the state are aware of these things. Now we're going to do a poll question. And the question is, which opportunity for improvement is most important to focus on this year in your community or in the state overall? So is it increasing access? Is it improving immunity or increasing awareness? So please take a minute to vote for which one you think is most important to focus on in your community or in the state overall this year. And we'll wait until we get a good response here and then share the poll. All right, so increasing access seems to be the area that folks feel is most important to address, and awareness really goes along with that. Okay, thank you. Now I'm going to talk about reducing the spread. Get to my next slide here, okay? Reducing the spread of bloodborne infections such as hepatitis C and HIV, and other things like endocarditis that Haley talked about. This is where we talk about syringe services programs or needle exchanges, which are an evidence-based strategy that really have decades of research on their effectiveness, particularly in preventing HIV. And we'll learn more about an SSP here in Columbus from Zach in the webinar in a little bit. In terms of strengths, Ohio has taken some initial steps in this area. So as of 2015, local health departments in Ohio are permitted to establish an SSP, and the number of SSPs has really grown in the state since then. And in July of 2018, the Department of Health submitted a determination of need letter. And what this means is that it's kind of opening the door for existing federal funds to support SSPs in the future. And then in the 2018-2019 state budget, we saw considerable funding allocated towards HIV prevention. Looking at gaps, despite the fact that we've had this really large increase in the number of Ohioans with hepatitis C, there really are no significant statewide efforts led by any state agencies to increase awareness, prevention, screening, and treatment of Hep C. And most Ohio counties still do not have an SSP, including some counties that are really high risk for an outbreak of HIV or hepatitis. These are a few graphics that illustrate these challenges, and this map shows the hepatitis C rate for each county, with the darker blue counties have the higher rates. The yellow dots are the SSPs, and then the counties with the red border around them are ones that have been flagged by CDC as being most at risk for an outbreak of hepatitis C or HIV. And you can see that we have a few counties in the state that are high risk but don't have an SSP. This diagram and the price tags along the left show that it's much more cost effective to prevent Hep C than it is to treat it downstream. The downstream consequences of Hep C include things like cirrhosis and liver cancer, and obviously cause a great deal of death and suffering. And that's why it's important to have a robust plan in place to address Hep C upstream. Here are some opportunities to improve bloodborne infection prevention in Ohio. So first, the state can launch an intensive initiative to reduce the spread of infections associated with injection drug use. And this could include an integrated state plan, similar to the plan that we have for HIV. We could have a plan like this for hepatitis C. Second, Ohio can increase the number of SSPs. And then third is to really identify sustainable funding sources for the existing SSPs and provide some coordination for SSPs in the state so they can share information about how to improve and expand their programs. We have another poll question here. Which of these opportunities do you think is most important to focus on this year in your community and in the state overall? So is it prioritizing and planning, such as having an integrated plan for hepatitis C, increasing the number of SSPs in the state, or sustaining and continuing to support the SSPs that we have? So please let us know which of these you think is most important. All right, Lana's gonna pull up the results here. Okay, so prioritizing and planning, really having a state level plan in place. And I think there may be some efforts at the Department of Health just to start to move towards this. And then also spreading SSPs. All right, thank you. The third topic I'm going to address is increasing access to hepatitis C treatment. So here I'm talking about two evidence-based strategies. The first is screening for hep C, particularly universal screening for people who inject drugs. And then the second is treatment with direct-acting antivirals, DAAs. These are a relatively new type of medication that actually cures hepatitis C. For strengths, but before 2019, Ohio Medicaid only covered DAA treatment for patients with moderate to severe liver damage. But starting this January, ODM lifted this restriction for both fee-for-service and managed care plan enrollees. So this means that Medicaid enrollees with hepatitis C will be able to be cured and not experience the more severe downstream symptoms and complications of hepatitis C. They'll be able to get that treatment sooner. But in terms of gaps, there still are many barriers to getting DAA treatment for Ohio Medicaid enrollees and for people who are incarcerated. So one example of this is the prescriber restriction. So Medicaid enrollees need to have access to a specialist, but many Ohio counties do not have the types of specialists that are needed. 14 other states don't require DAAs to be prescribed by or in consultation with a specialist. So really, primary care providers can do much of this work and are more accessible in many parts of the state. If you want to dig into those restrictions a little more deeply, I encourage you to check out the report. It gets pretty weedsy. And I just wanted to mention too that we focus here on Medicaid policy in particular because it's really relevant to state policy and because of the large numbers of Ohio Medicaid enrollees that have been diagnosed with hepatitis C. So this bar chart shows that trend. Here's a summary of opportunities to continue to improve access to hepatitis C treatment for Medicaid enrollees while exploring strategies to control costs, since we know these are expensive drugs. The first is to remove or reduce restrictions, such as the specialty provider requirement I talked about. The second is to engage primary care providers, including federally qualified health centers, more in screening and in treatment. And then the last point here is about financing and some recommendations from the National Governors Association to ensure financial sustainability for these specialty drugs. And we've got another poll coming up here. To hear what you think of these opportunities. So which one do you think is most important to focus on this year in your community or in the state overall? So is it increasing access in general by reducing those restrictions in Medicaid? Is it by working more with primary care? Or is it to control the spending and ensure sustained financing for these drugs? Obviously, these are all connected, but you can only pick one. Make you pick one. All right, let's see what these results are. Okay, I'm noticing a pattern here where the first response always gets the most votes. We got to mix it up. All right, so access and primary care were the two most popular options, and obviously those two go together. All right, go to the next slide here. Whoops, went too far. There we go. So that was a description of the strengths and gaps in Ohio's policy efforts related to overdose reversal and other forms of harm reduction. And the last point I want to make before turning it over to our guest speakers is that evidence-based harm reduction is really an underutilized tool in our state. Ohio can do more to incorporate harm reduction strategies as part of a comprehensive person-centered response to the addiction crisis. And as we all know, this is such a large crisis that we really need to be using all available tools. I also want to emphasize that harm reduction tools are particularly underutilized in some of our rural counties. This map shows what we're calling harm reduction deserts. So these are counties that have one or more of the following. So they have a high overdose death rate, but have no Project Dawn site or have lower EMS naloxone distribution rates, or they're at high risk for hepatitis C and HIV, but don't have an SSP. All of these counties are rural and may be struggling with inadequate funding, limited local health department capacity, and with stigma. Overcoming the stigma of drug use, particularly injection drug use, is a challenge that needs to be overcome in order to save lives and really implement these harm reduction strategies in the way that we need to be implementing them. And before I turn it over to our first guest speaker, I just wanted to share with you this tweet that I saw recently from a Philadelphia journalist. And the last part really got my attention, which is being alive is the only prerequisite for recovery. And that is really what harm reduction is about. And now I am going to turn it over to Dr. Sean Ryan, but first I'll briefly mention the key takeaways here. So this summarizes what Haley and I just talked about. These are the key takeaways from the report that we encourage you to check out. And now I will introduce Dr. Sean Ryan. He is the President and Chief Medical Officer at Brightview, which is an addiction treatment provider in Cincinnati. Take it away, Sean.
Thank you, Amy, and thank you to the HPIO for the opportunity to talk today. As Amy said, I'm Sean Ryan. I'm a board-certified addiction and emergency physician, so a little bit of an interesting background and training and focusing on this issue. Just to comment on a few of the really important and well done, informative slides that Amy went through. We are seeing some positive impact of all the efforts to date, including what I'm going to talk about today. But we have a long way to go, and the opioid crisis specifically is a very complex issue. It also, as many would say, is really a symptom of a broader issue of a mental health crisis and related social determinants of health issues. So today, I'm going to talk about the Narcan Distribution Collaborative, which is the largest Narcan distribution program in the United States in a major metro, that being here in Hamilton County, Cincinnati. Next slide, please. Just want to give credit to the team that came together to do this. Just a tiny bit of background. A couple entities came to me and said, hey, what if we were to really inundate or try to distribute as much naloxone as possible in a highly affected area, obviously Cincinnati being one of them. And I said, well, unless we really get a team of distribution and management, quantification and research together, then I probably can't be very effective driving it around in my truck. Not that I wouldn't have done it, but probably wouldn't have been the most effective methodology, nor would we have much to talk about from a measurement perspective. So here you can see the credits for all the folks, and it really was a monumental effort of teams, including all 5 healthcare systems in the region coming together, and the county commissioners, and a lot of folks you can see here on this slide. Next slide. This is going to be the agenda for my brief discussion as directed. Next slide. I'm not going to do too much background on how bad the crisis is. Amy did a fantastic job going through all of those things with some very specific details related to Ohio. But we are, what I describe, in the crucible of kind of the situation, although that is also changing. What you did see as she advanced through the slides related to different states and different stages, that is absolutely the case. Some of the other work that I do across the country, I'm the chair of payer relations for the American Society of Addiction Medicine and soon to take over legislation for that organization. And so in that role, I have a purview of a lot of things going on across the country. I also talk to a lot of my addiction specialty colleagues who talk about areas of states that have primarily still a prescription opioid problem and haven't transitioned to the disaster of heroin and fentanyl that we've seen in kind of our tri-state of Ohio, Kentucky, and West Virginia being the focus. So you can see here that region that we all kind of focus in, it is one of the highest impact areas, but one of the things that we're hoping to do is learn very quickly and do a lot of this good work that you've seen portrayed already, and then be ready to act proactively in areas as the opioid crisis continues to roll and morph throughout the rest of the country, as is quite obvious is happening. Next slide, please. I think this slide was showed before, if I remember correctly, but this was the basis for what we were looking at when the program was initially being discussed in 2016 and then into 2017. And I'll talk about when we started. But there was a lot of pre-work, as you might imagine, to get all of those players and stakeholders to agree to what we were going to try to do in a cohesive, comprehensive, and measured fashion. Interestingly, across that time frame, we saw a little bit of a kind of a fluctuation across months, as well as you can see here, 15, 16, and 17 in Hamilton County. There was some discussion, actually, to be realistic, at the end of, well, kind of during 17, because we had the 2016 numbers at that time, that maybe we had crested and we weren't going about this, in a necessary and appropriate way. I did not agree with that and felt that we had more to come, and obviously, unfortunately, in 2017 we saw that to be the case. And then, as Amy talked about, in 2018 we may have hopefully finally seen the crest in this region, and that's exciting and positive news, which is always good. Next slide, please. To talk about the program goals and outcome measures, we started with a primary goal of rapidly, essentially distributing about 25,000 doses of naloxone throughout the community, which again was the kind of highest volume and shortest time frame of any Narcan distribution program in the country at that time. And then attempting to reduce by greater than 50% the number of fatal opioid overdoses and those resulting in intensive care unit admissions. For those who might not see why we would be looking at the intensive care unit admissions, there's been studies in both Canada and the United States that have demonstrated how far up those admissions have gone, because fortunately, and thank goodness, not everyone actually has a fatal overdose from opioids, and in fact, far more people don't pass away from their opioid overdose than do. And so there's been a really sharp increase in ICU admissions as a demonstrable and high-cost healthcare impact that the overdoses have that are not measured in the coroner's reports that we all see hit the news so frequently. The outcome measures are, as you can see here, number of doses distributed, doses administered, so tracking which ones kind of were used, and then number of proportion of opioid overdoses that result in death or ICU admission. To be very clear, we don't have all of this data yet. This is kind of a mid-effort presentation, which we've been doing, since probably 6 months post, because despite the academic rigor of attempting to really quantify what we're doing, we're seeing such profound impact or related impact that we wanted to get the information out sooner rather than later. So I won't be demonstrating all of these things in a report fashion today. Next slide, please. What we have gleaned is a lot of data. So in any kind of public health project like this, it is very challenging to make sure that you always focus on obtaining as much data as possible. As one might imagine, and I'll talk about it in a second, one of our high impact and high distribution points has been the syringe access program in Hamilton County and surrounding counties. And a lot of those individuals are not ready to give their information, and so we've been a little, we've had some challenges related to data collection, but they are acceptable ones. The fact that we would never deny an individual because they wouldn't sign a form and give their real name. So the data we are collecting is, according to the public health and other analysts that have been working alongside me as the primary investigator in a public health form, is really good. Not as good, of course, as a randomized control trial in a healthcare setting, but good nonetheless. And you can see here just kind of some general data about what we distributed. It's a little interesting in the fact that we are distributing so quickly that I can get data that's 20 to 15, 30 days old, and it's already substantially different at the time that I present, as is the case today. So we've already, I think the number I heard yesterday was actually well over 30,000 doses distributed at this time. And to be very clear, because there's some mixed language in here, cartons have 2 doses. So anytime it says cartons, that's 2 doses, so it's times 2. Next slide, please. This gives a good graph of kind of what you can see for naloxone distributed in Hamilton County. One of the things that we're doing is also attempting, to the best of our abilities, to track all other naloxone distribution efforts, because, again, good news is the Narcan Distribution Collaborative, as big as it is not the only entity doing this, but trying to coordinate with others and trying to collect data so that we know kind of what is the most optimal distribution methodology that we can use in other areas of Ohio potentially, as well as other areas of the country. So you can see here, again, the Narcan Distribution Take-Home program that is primarily directed at individuals, as was demonstrated so clearly in Amy's slide about bystander distribution, primarily directed at kind of the public, both patients and their closest relatives or friends, etc. The dip that you see, I'll explain in kind of July and on, was we were managing an ebb and flow of available medication to the best of our abilities through the distribution allocations that we have, and we weren't sure that we were going to continue to be able to go as fast and as hard as we had been in the October to July range. And so we started looking at, as every community has to do, kind of with limited resources, what are the highest and best impact points that we can distribute. But the fantastic news is that the work has been going so well that we were kind of refunded and reallocated much more. So this graph will continue to look very robust on into October of 19 per the goal of the program. Next slide, please. This slide has been very informative, maybe even one of the most. The reason I say that is because what we know is that folks use and overdose and obtain their drugs and travel, etc., far outside their home area. And so these are the residential zip codes as given to us, as reported by individuals that were given the distributed Narcan throughout. So this is quite a bit larger, as you can see, than in Hamilton County. Much of it reaching into northern Kentucky, which is really important because although many of the barriers we deal with on a political and reimbursement side are siloed by state, patients are not. And so this really clearly further demonstrates what we know to be the case, which is drug use occurs in a very distributed fashion across communities. So it's important that efforts realize that and always recognize when possible to coordinate throughout, outside of county lines. And that includes something I'll talk about in a second, which is treatment. Folks, as you might imagine, if you attempted to get everyone that is on this map into treatment in Hamilton County, that wouldn't work for a lot of different reasons. Next slide, please. These are the types of sites where individuals were distributed the Narcan distribution take-home cartons. You can see very clearly here, and I'm happy to have the next guest follow along with more information on syringe exchange, which is so important. But that is, potentially the highest risk population, and so we've really focused on distributing there. We've also had a wonderful relationship with the Hamilton County Jail and the sheriff, Sheriff Neal. I'd like to send them and their staff some commendations for allowing us to distribute in the facilities, which is a unique thing where many folks are aware that an individual who's in jail and not having access to opioids goes through withdrawal. Their highest risk point, of course, is when they're leaving. And we've had also a lot of families who've taken, so it says visitors there, a lot of family members and friends who've taken naloxone knowing that their loved one who's in jail when they get out will be at high risk. And then on down the line, looking at all of the other types of distribution points and analyzing what we can about that. Next slide. The other great news, and I continue to be positive about all of this, as is my job, is that we have really seen a large related impact. Again, we can't given this is a public health program, and there's a ton of factors in analyzing any of these things. Can't claim causation by any stretch of the imagination, but correlation nonetheless. And we've seen basically everything going in the right direction. So ED visits going down, EMS runs going down, and drug overdoses and drug overdose deaths going down. And so what that means, because there was some question around, well, if people aren't going to the ER, is that appropriate? And the answer is yes, as long as the mortality is not going up. I've also had questions to be very direct about, well, aren't people getting treatment in the emergency department? And the answer to that is no. Happy to answer any questions about that at a later time. But until recently, my organization, Brightview, is doing a large program with the Department of Health and a lot of other partners across the state to bring up more intervention, including MAT, in the emergency department. But across the course of this program, that has not been the case. And so I was not concerned that we would be putting individuals at risk by not allowing them to go to the emergency department, although, of course, we encourage anyone and everyone that we distribute to call 911 and send people to the emergency department for appropriate triage and evaluation. And it is my hope that as we look in the ED linkage to care programs or ED comp care programs, that we see treatment being initiated in ED in the next year or two much more robustly. Lastly, and not presented here, is that we've seen a continuous and significant increase in at least the Medicaid data for treatment, for folks entering treatment along this time frame. So if you take all of those 5 factors together, that's really what I hold to be the goals of these things that we will be tracking, in addition to the other things like I mentioned, ICU, which will be later data we'll collect, a kind of post hoc analysis. Next slide, please. This is just a bar graph demonstrating kind of pre and post intervention as to what we've seen. Other communities doing all of these cohesive efforts, like Montgomery County or Dayton, have seen similar decreases, if not more or less, depending on which county we're talking about. And so we're happy to say that we believe to be the case, significant community naloxone distribution is a pillar of dealing with the opioid crisis and opioid overdose deaths. Next slide, please. Challenges that we've seen include compliance with all appropriate regulations. So what does that mean? There are actually a lot of rules around distributing a prescription medication. This is not over the counter and it's not controlled, but it is still prescription. And so there are a large list of protocols and policies and rules that we have to follow. The State Board of Pharmacy in Ohio has done a very good job of working on this issue, and I'd like to thank them for that. We still have some things that we could manage better if allowed, and working with them, I think we'll come to those goals. And so, we're lucky to have the progressive regulatory authorities we have in Ohio in some ways, and we still have some ways to go on that. And then lastly, acceptance by the public, still a very big problem based on stigma. I'll make the following statement. I don't have any delusions of grandeur that we're going to get rid of stigma entirely in the next few years, but we've come a long way, and I think we've got a lot more that we can do. And so I think that that's a huge goal for everyone working on the issue. And then syringe exchange programs got to be expanded. Those are so key and critical to all of the things that are related to the opioid crisis, infectious disease, treatment connection, etc. And then I'm going to personally be working on with my team more jail-based distribution programs because of that area of focus, being keen on preventing high-risk patients from going without naloxone. I believe that's the last slide. Oh, and in summary, massive naloxone distributions by public health entities can have a possible, substantial positive impact. Again, not just on the overdoses and all the things we're talking about, but on stigma itself. So because public health and medical professionals and others are talking about this and interacting with the community, et cetera, it really does serve as a messaging platform for stigma reduction. I would also say that we still are a long way from where we need to be in these massive naloxone distribution efforts. I would estimate probably less than 10% of goal throughout the state of Ohio, so we have a long way to go. And then last and probably most importantly, treatment has to be the next step in the patient's journey, and treatment with medication-assisted treatment as is evidence-based and very clearly the best and most appropriate standard. It's extraordinarily important we're expanding that ready access for treatment on demand to MAT in every community, because otherwise naloxone is very temporarily a measure to save that person's life. Thank you.
Thank you so much, Sean. I'm gonna we'll just give it a minute here for questions for Dr. Ryan. I do see two questions here about naloxone distribution. I'm not completely sure if they were meant for you, Sean, but we'll see if you have an answer for either of these questions. The first is,
Sure.
Is naloxone distribution to Ohio professional first responders, law enforcement, and fire a high priority? And then the second is, how are NIOSH guidelines presented to opioid overdose first responders?
So those first responders of all types are a very important distribution point. Absolutely. Thanks for that question. They're often, unfortunately, we don't have enough naloxone in bystanders' hands, as was demonstrated by that slide. And often the first person that arrives is the first responder. But we want to make sure that basically both parties. We don't want either person to not be, not have naloxone available, because for very specific reasons, people begin to have brain injury, brain death within the first 4 to 5 minutes of anoxia. So we have an extraordinarily short window within to reverse opioid overdoses without significant consequence. And as stated with the ICU admissions and other stroke type related and pulmonary injury, et cetera, a lot of people don't die from the opioid overdose, and people think that's the only measure of success or impact point, but it's not. We have a large number of people who are suffering other types of significant injuries, resulting in detriment to their life as well as significant healthcare costs. And I'm sorry, I'm not familiar. I mean, I know what NIOSH is, but I'm not familiar with what specific, so I may not be able to answer that question.
Okay. All right. Well, in the interest of time, I'm going to move us along to our next speaker, who is Zach Holmes, who is with the Harm Reduction Program at Columbus Public Health. And this webinar may go a little past 11:30, but I promise you we have interesting stuff. We have Zach's presentation, and then I have a few additional remarks and some closing poll questions, and we will also take general questions at the webinar. So I encourage you to stick with us a little bit past 11:30 if possible. And now I'm going to turn it over to Zach.
Hello, everybody. I'll try to be respectful of your time. My name is Zachariah Holmes. I am the Harm Reduction Manager for Columbus Public Health. I spent the past 5 years working pretty much as a provider and of services, not as a manager, so I'm pretty new at this. So I'll probably repeat a lot of the numbers and ideas that you heard, but maybe some of the policy questions, if you have any, I'll have to get an answer for you, okay? But if we put up the presentation, please. Next slide. So we have our syringe service program, which we call SafePoint. So if you hear me say SafePoint, I'm just referring to our hybrid exchange, which I'll talk about a little bit. So everyone, I think it's been kind of repeated through the different presentations that syringe service programs are really important, and we all know that harm reduction focuses on ways to try to minimize the health risk, not just to the person who's using drugs, but also to the community, rather than just try to ignore them or condemn them. Obviously, social justice model, we understand that people who use illicit drugs, especially people that are visiting SafePoint, our program, are clearly a vulnerable population. And as the little quote earlier was put up from, I don't know, someone's Twitter feed or whatever it might be, that, keeping people alive and happy and healthy is really just the most important thing. So, we really just try to focus on creating a judgment-free environment and meeting people pretty much where they're at in their with their use. Next slide, please. And this includes, public education, prevention, and treatment. Any syringe access program is going to really not just reduce the risk of IV drug use directly, infectious diseases, untreated medical needs, and unintentional overdoses. Next slide. So part of the reason that they're important is there's a lot of research out there, right? But obviously we want to care for people. That's a big deal, and meet people where they're at, and hopefully eventually lend them into treatment, and medical treatment that goes along with that. Essentially, let's see, as it says, people who inject drugs are 5 times more likely to enter a treating substance treatment for substance use disorder and when engaged in a program. So our program, as people have talked about Hep C before, came about solely because in 2015 and 14, we test a program that I managed and was a part of was out testing only in the recovery community or with people that were active addiction for things such as HIV and Hep C. And we were having a positivity rate of upwards of 30% for each year. So that led us to kind of start working on and trying to work with the CDC and get legislation passed to start a safe point or syringe access program, because I would say, and it's pretty well backed in research, that SSPs are pretty much the cornerstone of Hep C prevention. People who inject drugs account for about 68, almost 70% of all hepatitis C infections in the U.S. So it's one of the best ways to combat that. So when we had that high positivity rating in 2015 and 14 is when we kind of looked to start this model. Next slide. So the federal funding, the Consolidated Appropriate Acts. So basically, the CDC and the federal guidelines go along with it. Under legitimate circumstances, you're allowed to get certain funding, as we know, for certain aspects of a syringe access program or an SSP. But obviously, the use can't be for needles. Okay, so that is how we came about. So the way the legislation is written here, essentially, is that we oversee it. So City Council and the local health department, Columbus Public Health, oversees and helps fund the needle exchange, and that's how it's allowed to be open. We don't purchase any needles, but again, in 2018, we had a positivity rate of about 40% for Hep C, which is pretty staggering. And again, we know that this, even though we get some federal funding for things such as maybe an alcohol and drug treatment counselor and so forth, we know the average cost of treatment for Hep C is around $90,000. So when there's over 4 million people living with Hep C in the U.S., any program that is going to be most effective at reducing that is really going to save people a lot of money and help keep people safe and healthy. Next slide. This is just more or less stating what I already said. Let's see, next slide. So this is a map of just the different SSPs that we have by state throughout the U.S. We're getting there in Ohio. Obviously, I don't think there could be enough whatsoever. Next slide. So again, this is just talking about kind of what we talked about, or what I was saying earlier, that our local Board of Health established a program which started in 2016. And so when it says consult with interested parties, we work with Equitas Health, but that's the oversight piece that we're talking about through the Ohio Revised Code that allows us to test there and to basically have a program, a syringe access program or Safe Point, in order to try to lower the numbers of infections that we have, get people to treatment, and so forth. So at Safe Point, I guess I'll talk about that in a second, but can we go to the next slide, please? This will just tell us more about, there's currently 14 syringe programs in Ohio, operating in 16 counties. So it's a huge increase since 2015, when there was only one program operating, and I believe that was down towards Hamilton County, if I'm correct. But next slide. We have partnered, like I said, with Equitas Health and start our program. And in 2015, in our first year, we saw well over almost 1,700 different clients. Next slide. And then, so this talks more about the program, which I kind of been talking about. Next slide. This is just some numbers and outcomes of 2017. Initially, we started as an access program, meaning that you didn't need to bring anything to get anything. So when people come in the door, they do have to fill out a kind of a what I would think of as a harm reduction questionnaire that asks them about their use, their readiness to change, the risk, and the services that they provide. At SafePoint, we provide not just access to clean work, so waters, or cottons, cookers, tourniquets, alcohol swabs, and obviously clean needles, but we also have an AOD counselor present every day there that works either here at our treatment center or at a local methadone clinic so that they're able, or MAT center, so they're able to get linked to care if need be, or help get referrals for housing and other needs they might have. We offer HIV and Hep C testing there. There's condoms, there's wound care. We're working on getting pregnancy testing there. We have had a nurse off and on there for wound care, but not all of the time. So it's a fairly encompassing program, I would say, because we're doing a lot more than just distributing needles. In October of 2018, we switched to a hybrid exchange, meaning that upon your first visit, we give 120 needles, and then for each additional visit after that, you get 10, and then we go 1 for 1 on top of that. So if you come in, if it's your second visit, we'll give you 10, then, but for every needle you give back, we'll give you 1-to-1 with a maximum of ability to get 300 needles for the month. And just in that first 3 months that we had open, we actually collected throughout the I want to say it was 280,000 needles through 2018. So the switch has been good as far as collecting back needles and disposing of those as well. And we distributed over 985,000. So it's clearly been effective in the past few years since it's been open. Some of these numbers will just tell you unduplicated services. We wrote over 1,500 referrals for alcohol and drug treatment, over 470 behavioral health, and over 1,000 medical referrals. Obviously, the primary drug of choice was heroin, but there are a few others that are enlisted in there. And I mean, we do get people that come in occasionally that are there just for other people that they know, or their sons or their daughters, or their brothers, sisters, husbands, so forth. Not shocker that, because the numbers state that the majority of the people that we're seeing are male. And again, our Hep C positivity rate is it's self-reported, but even through our testing, it stayed high, close to almost 40%. We do naloxone distribution there too. I guess I didn't mention that earlier, but there is a pharmacy present in the facility that we're at. So naloxone distribution happens every day that it's open, and we just moved to a new site. So we're going to be open hopefully 4 days a week. We had been open only 2 days a week for the past few years. But yeah. Next slide. So this is, again, I talked a little bit about our Hep C rates, and you can see that they did start to spike in 2014 and 15, which again brought attention from our epidemiology department looking at the numbers, because as far as I know, after talking to HHS, Health and Human Services, we are the only alcohol and drug prevention or treatment program that actually has people that go out and test specifically people that are in treatment here and then out into the community as well. So our program, our HIV Early Intervention Services program, is the only one that's actually that they're aware of as well, that goes out and tests people that are active in addiction or in some form of recovery at some level of care. It doesn't matter which to us they're in. We'll still be there testing, whether it's outpatient, detox, so forth. Next slide. And in interest in time, there are citations for any of the stuff that I said if you want more information about any of this. But yeah, obviously there are tons of associated harms with substance use disorder. You know, a good comprehensive harm reduction based SSP program should look to reduce pretty much most of those harms. And, you know, we're just hoping to have good outcomes. And really, the public health response has to be multifaceted, not just in all the services that we're providing at the program, but with community partners and community engagement, buy-in, and so forth, and local law enforcement and first responders. And that's part of the reason that we switched to a hybrid exchange, because of the pushback from local law enforcement. So that's it.
All right, thank you so much, Zach. We
Yep.
do have one question here for you that
Yeah.
someone has typed in. This is from Brittany Ward in Northwest Ohio. Do you have any recommendations on how to combat stigma surrounding syringe exchange programs in rural conservative communities?
Stigma, I think one thing that is a few notes. I guess I have two ways to approach that. One is I often like to tell people that I believe in self-determinants of health, as I think most people probably do. But if someone smokes and they have emphysema, a doctor will not deny them access to oxygen. If someone is diabetic, type 2 diabetic, because of their diet, no one is going to deny them access to a piece of cake. So I think it's kind of always important to think of people with substance use disorders as people first, and not as a person with an addiction, but as a person first, and understand that we don't deny care to other people that have problems that they might have potentially brought upon themselves through their lifestyle or, their own behavioral health choices. So I think that's one aspect that you can talk to people about, and sometimes that's an easier pill to swallow. And then also the cost effectiveness. A lot of people don't like the idea, and it's why we're not allowed to buy syringes with federal funding and our local money that we get here. But I think it's always important to talk about the long-term cost effectiveness of an SSP. The state of California, their Office of Statewide Health and Planning and Development estimated in, I think, 2006, the associated cost for liver disease for people infected with Hep C was over $1.4 billion. So when you look at that, or the lifetime cost of treating someone with HIV is anywhere around $400,000 to $600,000 in the lifetime, that not only are we reducing the risk of that person, but that burden also doesn't get passed on to the taxpayer. And sometimes that, unfortunately, that's not the most empathetic answer in the world, the one that deals with, money or monetary issues, but sometimes people can see their head around that one as well.
All right, thank you. That's really helpful. I am going to move us along here to talk about what you can do to contribute to this work. And we will have a little more time in a few minutes here for some more general questions. But here are 3 things that you can do with the information from this webinar. The first is to disseminate the information. The second is to educate our policymakers. And the third is to partner with other organizations. For dissemination, we really encourage you to share the link to this report with all of your contacts, and we are always happy to provide hard copies of the executive summary if you want to hand it out at a meeting, and we're also happy to come and do presentations. So if you are involved in planning a conference and would like to have us come and present on this content, please reach out to me or to Haley. And we encourage you to check out the Addiction Evidence Project website on the HPIO website. You can find all kinds of detail if you really want to dig into the weeds of what we talked about today. And we encourage you to follow us on Twitter. And in terms of educating policymakers, we encourage you to pick some of the opportunities for improvement that are in the report, including some of the ones that we had the poll questions about today, and reach out to your legislators, state agency leaders that you might interact with to talk about how we can move these ideas forward. And even if your organization doesn't do direct lobbying, you can still educate legislators and state agency folks and local policymakers as well. You can help to build bridges between prevention, treatment, recovery, and harm reduction organizations. So if you don't know them already, get to know your local health department, your first responders, treatment providers, hospitals, grassroots organizations, and really explore ways to expand harm reduction in your community and overcome stigma and begin new harm reduction activities. Got another poll question for you, which is, how do you plan to use the information from this webinar? Pick the one that you are most motivated to act upon. So are you going to disseminate the scorecard report, educate policymakers, build partnerships, something else we didn't think of, or none of the above? And if you are checking something else, please send us a note in the chat box to let us know what that is. We'd love to know how this work can be used at the local level and the state level. Okay, that first response option got the most votes again. So disseminating the scorecard report, so that's great. We need all the help that we can get to spread the word. And then also a lot of folks building partnerships with other organizations. That's great. And moving us to the next slide. We will take a few minutes here for questions. I see that some questions have already arrived in the chat box. As you are typing those in, I just want to acknowledge the core funders of our work here at HPIO, and a special thank you to Interact for Health and Premier Health for their additional support specific to the Addiction Evidence Project. We could not do this work of diving into all of the legislation and regulations and state agency programs if we didn't have this support. So I'm going to circle back to a question that we had earlier in the webinar, which was, does the report address concerns about how the Good Samaritan 3 strikes law is tracked? So for those of you who may not be familiar with the details of Ohio's Good Samaritan law, there is a provision that you can only get the immunity the first 2 times that you report an overdose. And if you are present at 3 overdoses and are trying to use that immunity, it no longer works. The challenge here with implementation, obviously, is keeping track of that. As far as we know, this is not being tracked in a comprehensive way. And so the implementation is not really fulfilling the intent. And it's certainly an area that could be improved. And then we also had a question about the overdose death rate. It said Ohio's ranked 2nd in overdose deaths. Was this general overdose? So Ohio has been ranked, sometimes you see it 2nd or 3rd for overdose deaths, depending on the year and depending on if it's specific to opioids or drug overdose in general. The other important thing to keep in mind is that state overdose death numbers are looking at unintentional overdose deaths, whereas when we look at US data or data from other states from CDC, they are including unintentional and intentional combined. So those numbers can look just a little bit different. And let's see, what other questions do we have? Someone here talking about the importance of engaging clinicians in naloxone distribution. Great point. No other questions? All right. Well, thank you so much for sending us questions, and you can continue to follow up with us. We have one more poll question for you before you leave the webinar. Overall, how would you rate the quality of this webinar? Excellent, good, okay, fair or poor? And as you're filling that out, or just a reminder that we will be posting the slides as well as a recording of the webinar on our website. So we encourage you to check that out and to share it with your partners. All right. Thank you so much for your interest in this work, and stay dry.